Good morning. Today we'll be talking about sexual health, optimizing your sexual health. Thank you, Dr. Toyin and Dr. Leye Ajayi. It's a pleasure to have both of you back on the program together. And for clarification, we have Dr. Toyin, who is a gynecologist, speaking about women's issues. And we have Dr. Leye, who's a urologist, consultant urologist, speaking about men's issues. So if we could start with ladies first. Dr. Toyin, can you define sexual health? What is sexual health?
Thank you, Dr. Pamela, for having me on. Yeah, so sexual health is a state of physical, mental, and psychological well-being as it relates to your sexuality. And it kind of requires you to have a positive outlook in terms of your sexual relationships. And it also encompasses the possibility of having sexual experiences that are free of coercion, free of discrimination, and free of violence. So that's how WHO defines sexual health.
Well, I think sexual health is part of one's overall health. And I just wanted at this point to make clear that we're not speaking in any religious or not religious context, and we're just speaking about sexual health as part of the overall health of an individual, because sexual health is related to reproductive health. And it's important that we address issues as sexual and reproductive health are a very important part of any individual's psyche and well-being. So can I ask, what are the issues that we could define as related to sexual health that actually are associated with reproductive health?
So I think the main issues for women is obviously the burden of sexually transmitted infections. So I think in our part of the world, a lot of the infertility that we see is actually caused by, a history of sexually transmitted diseases in the past in the woman. So, I know that here in Nigeria, secondary infertility is a major factor, is sort of the main reason for infertile couples. And that means that they might have had a child before, but then they struggle to get pregnant again. And we also know that the commonest reasons for that tends to be due to tubal blockage. So they have, their tubes are blocked, therefore they can't get pregnant. And then what's the most common reason that we see in this part of the world for having blocked tubes is usually a history of sexually transmitted infection, such as chlamydia, commonly, when one is younger. So that burden of that, and I think, again, because we're in a poor resource setting, a lot of times these STIs have gone untreated or they've been poorly treated. And therefore the impact that they have, the damage they cause, will then result in that long-term effect and cause infertility in the woman.
Yes, and we thank goodness that British Clinic is there to help them overcome those reproductive issues. Dr. Leye, can you tell us about what the issues are in the men?
Firstly, Dr. Pamela, thank you for having me on this show, this educational podcast. For men, as Dr. Toyin mentioned, sexually transmitted diseases are a common factor, but in men, as far as their sexual health is concerned, issues around erectile dysfunction is a real problem in a lot of men, and also around premature ejaculation. There's the whole psychosocial aspect of their sexual health as well that one has to take into consideration.
If we could just define, what is erectile dysfunction? What causes it?
Yes, erectile dysfunction is an inability to attain or maintain for satisfactory sexual intercourse. And you have to look at that definition. In terms of the causes of erectile dysfunction, it's multifactorial. There are psychogenic factors, which occurs in most men, or organic factors, and organic factors are clinical conditions such as diabetes, hypertension, and what we see very common, especially in our younger generation in Nigeria, is patients who've had sickle cell disease, who for some reason have developed a priapism, and they've lost the functionality of the muscles within the penis, and they develop erectile dysfunction.
So you've just talked a bit about the erectile dysfunction. Are there any risk factors?
There are many risk factors for erectile dysfunction, and most of which are all well known, and each individual recognizes it. When a man is slightly overweight, obesity is a risk factor, often because people who have a high body mass index tend to smoke, tend to be diabetic, tend to have hypertension, have high cholesterol, and most importantly, have cardiovascular risk factors. Those are the main risk factors to worry about. Also, people who smoke, very high, and that's probably the most important risk factor for erectile dysfunction.
And how do you diagnose it? What's the...
Often it's the patients come forward, we take a history, we examine the patients, and there are a number of key investigations that we would do to investigate that in more detail. So often from the history, the patients tell us, they come to the clinic and they tell us, look, I'm having issues around my erections. There's some very key important lab tests that we would run when dealing with patients with erectile dysfunction. Often, for man, the key test that I've mentioned to you, some of the risk factors, we always look at their lipid profile, their cholesterol level, check whether they're diabetic, we check their HbA1c, it's a blood test to tell us roughly how well their blood glucose is controlled. Most importantly, we check what's called the pituitary gonadal axis hormones. These are hormones produced by the brain, what's called the anterior pituitary of the brain, which stimulates the testicle and allows the man to produce a hormone testosterone. So the testosterone in a man is the real key to really ascertain and understand the quality of one's erection. If they have a low testosterone, there are many reasons why, but we always worry about this acronym called ADAM, androgen deficiency in the aging male. Okay, ADAM it stands for. This is very similar to the male menopause, essentially. So we're checking a man's testosterone, and we always check it in the morning because we know that, believe it or not, a man's testosterone is highest in the morning between the hours of 10 and 12, not at 8, 9 o'clock at night after they finish a busy day's work. So we always ask for a morning testosterone level in men.
Now, this ADAM, and can you sort of elaborate on it a bit more? When does it take place, this male menopause? Or what age? So the people who are listening can understand a bit more about it, just in case they're experiencing it themselves.
It's often a middle-age issue. So you're talking to men over 40, often around 50, when they suddenly develop a lot of symptoms. Loss of memory, very easily agitated. They change their body mass changes, so they put on weight around, especially the midriff. Their sleep is poor. They might develop hypertension or diabetes. So it's kind of the middle-age spread that happens in men, just similar to perhaps might happen when a woman goes through the physiological changes of menopause. And we see it in men where they lose interest in sexual activity. These are men who are normally considered themselves, quite virile. They hit middle age. They have absolutely no interest in their sexual interest is lost. So they will often come and see us. We check their testosterone. We find it's low.
That's very interesting. Before I'll come back to you with the premature ejaculation, but I'd like to speak to Dr. Toyin first. Dr. Toyin, what about women in terms of women's libido and issues around their sexuality? Is that an issue in terms of sex, in terms of reproduction?
So, I mean, it's not something that we see a lot, I think, in terms of infertility, but definitely, obviously, I think, like Dr. Leye mentioned, we do know that as a woman is approaching menopause or getting menopausal, then reduced libido is one of the factors that she will experience, mainly due to the reduction in her one of the hormones called estrogen, which is what's really responsible for the libido in women and the sex drive and so on. So a lot of women might come, around in their late 40s, early 50s, and we do see some of those in clinic. And maybe part of the reason why they're even struggling to get pregnant because they didn't have libido, they didn't have the desire. That might be coupled with maybe the husband is a similar age, maybe he's also going through ADAM and the sort of male menopause. So you then have two factors contributing to the fact that this couple is struggling to get pregnant. But obviously, in terms of like I said, as a direct cause of infertility or subfertility, I wouldn't say it is, but definitely we do see that, in women of a certain age, and it is unfortunately a natural part of, progressing, especially when you get to the menopause. But the good thing is that there is, options for management, in terms of hormone replacement therapy or counseling and things like that to try and help, get through those areas.
Well, I think that's very important. I think understanding sex and sexuality. And there was something you mentioned, Leye, about the psychosocial effects um, on the man. Could you just elaborate on that?
There's a stigma associated with a man who can't really perform, so to speak. So it is normal when a man is stressed, they release counterproductive hormones such as noradrenaline. And when a man thinks he's not going to be able to get an erection, he's not going to be able to get an erection. It's as simple as that. The fact that he's thought about it for a split second, it's over. Okay, so there's a strong psychogenic and a psychological aspect to a male prowess. They feel they can go and conquer the world. He needs to feel good about himself. If for a split second he hesitates and thinks otherwise, then sadly it is over. So they release a hormone, noradrenaline. Okay, it's a parasympathetic hormone, and that noradrenaline is bad for one's erection. And if you're stressed in any way, you release this stressful or adrenaline, for example. You release this stress hormones. That in itself is very much counterproductive to being able to obtain a satisfactory erection.
How does a man overcome that psychological issue? Can he overcome it?
Well, certainly. I mean, often they do come to seek help, and that the help can come in different formats. It could be psychosexual counseling. You've got to try and find out the root cause for that anxiety level. So it could be COVID, is recovering from COVID or anxious about COVID, lost their job, or various other life events that can take place. But if you're talking about the actual act of sexual intercourse, then we would always encourage the patient to see a psychosexual counselor. Okay, they might be able to talk them through it. From a medical perspective, we use medication in an effort to help our patients. There's a class of medication, which I'm sure you've all heard of, called PDE5 inhibitors. These are drugs like Viagra or Cialis, Sildenafil, or Spedra. Now, I always use the analogy for using these drugs as stabilizers. Imagine when a child is trying to ride a bicycle, trying to learn to ride a bicycle. They often have a set of stabilizer wheels on the side, which allows them to gain confidence. And once they're confident, you remove the stabilizers, which allows them to go forward. So these class of drugs, I tend to call them, in this sort of situation, stabilizing drugs, i.e. just to give them the confidence that they are able to function adequately. And after a while, the anxiety level passes, so they can stop and hopefully discontinue the medication, the stabilizers, for them to function.
Now, talking about the last thing you spoke about, which was premature ejaculation.
Yes.
What is premature ejaculation? What causes it?
Well, I think it's important really that one has to define the term premature ejaculation, because our patients enter our clinic and they say, "Oh, doctor, I have premature ejaculation. After like an hour, I have, my orgasm happens after half an hour or 20 minutes. It's too early." But you have to look at the definition of premature ejaculation, and that's what's called intravaginal latency time of less than 1 minute. i.e. within a minute of vaginal penetration, the man arrives at a very high excitatory phase, resulting in orgasm. So under 1 minute, basically. And it's quite interesting. There's been some interesting studies looking at it. Believe it or not, how long does it take an average man to ejaculate? And there's been studies looking at this scientifically, and it's roughly 5 minutes from penetration to orgasm. So believe it or not, it is not long anyway, in the vast majority of men.
Well, I mean, a lot of people will find this very difficult to believe, because most people actually base it on perhaps pornographic movies, etc., that they've watched, and so they have an impression that they have a problem, perhaps even when they don't.
Correct. Yeah. And part of my role is to educate our patients that in the vast majority of men, the average intravaginal latency period is under 5 minutes. And that often reassures them that they're falling within the normal cohort of a normal situation. So it's quite interesting that men assume that it's longer, but it isn't. These are scientific studies.
But just in case a person does have that problem, as you mentioned, under a minute, how is it treated? Can it be treated?
Well, it can be treated. Often the first thing is, again, seeing a psychosocial counselor, understanding why is it that happens. Some of these men are in arranged marriages, virgins before they got married. They've never had erections sufficiently. So it's very often for them to get very excitable very quickly, resulting in premature ejaculation. So there's a lot of counseling involved. There are medication we use in an effort to reduce the speed of onset of ejaculation. And these are drugs that are a number of called antipsychotic drugs. They're short-acting antipsychotic drugs. Essentially, they wash out of the body very quickly. They take it an hour before intercourse, similar to the way one takes the PD5 inhibitors. You take it an hour before planned sexual activity, and often within 3 or 4 hours, the drug is washed out of the bloodstream. So these drugs improve and lengthen the intravaginal latency period in order to have adequate and sufficient sexual intercourse.
What is the role of drugs and disease in sexual function? Because a lot of people say, you know, I'm on antihypertensive drugs or I'm on diabetic drugs, and that's the reason why I have a problem. Is there a role that drugs plays in this, maybe erectile function, dysfunction, or even premature ejaculation or anything else?
Yeah, I think one has to look at the patient. Often, a lot of these patients have a thing what's called a metabolic syndrome. This is an issue for a lot of men. Again, it's like we've talked about Adam. So Adam is often a patient who's overweight, who have hypercholesterolemia, who have hypertension, who's diabetic, who might have cardiovascular risk factors. So these are all factors that can cause a problem. Now, it's a chicken and egg situation. Which came first? They're on drugs for cholesterol and they have hypercholesterolemia. Is it the hypercholesterolemia that causes erectile dysfunction, or is it the statin they're on that causes erectile dysfunction? The jury is still out on this. No one really knows. And there are studies looking at whether or not the statins they're on itself can cause hypercholesterolemia. It is not uncommon for some of my patients to come to my clinic and say, I blame my antihypertensives for my erectile dysfunction. And it's not always the case. It's actually the fact we know that erectile dysfunction is a cardiac or cardiovascular problem. And that's what's caused the erectile dysfunction.
So, Dr. Toyin, you talked a lot about how STIs are a problem. How do women protect themselves to ensure they have a safe and healthy reproductive life?
Yeah, and I think that's a great question, and I think it's a really important question. And I think it really has to just start from education at a much younger age. A lot of people might feel uncomfortable with maybe their daughters in secondary school, having such detailed sex education classes, but actually in the long run, we're trying to protect their reproductive health. So, because a lot of times, a lot of these STIs are because of just not really understanding how to protect yourself, not understanding the true ramifications of the long-term effects. When you're in your 20s, you might not be thinking about, wanting to have a baby in your 30s. You're just, you're exploring your sexuality, or maybe, so that's sort of what you're focusing on. So I think we have to start at a much younger age, just in terms of having it a part of the curriculum in school for education, just to explain to the girl child, really, the importance of keeping yourself safe, the importance of safe sex using condoms, the fact that, condoms will protect you, from catching, STIs to a large extent, essentially. A lot of people think maybe just being on a pill to prevent pregnancy also covers you for STIs, but of course it doesn't. So it's important that that education is there in terms of, barrier contraception, safe sex practices, and then seeking help, if you do happen to catch an STI, then ensuring that you do actually seek help, professional help, trusted help, in order to get the proper treatment, in the right time frame, so that the impact on your future fertility is not as disastrous. Because we do see a lot of this
Yes.
in our clinic.
I think in our environment, we have a lot of people who say, oh, abstinence, abstinence, and then they don't want education because they believe everybody should be abstinent. But the reality is the exposure that that they have is that actually the reality is that the children are having sex at a younger and younger age and just pretending. And so everyone, essentially is pretending. And this problem is getting bigger and bigger, with a lot more infertility happening later on in life. And it does also happens for the boys as well. So I don't know, what should we be looking at? How should we be dealing with this?
I think we just have to be honest and truthful. Like you said, in our environment, it's very hard to accept the fact that our children are having sex at younger ages. It's very hard to accept that, but that's a reality. The exposure now from social media, peer pressure, all sorts of things are so much more than it was maybe in our generation for the younger generation now. So I think it's just an acceptance of the fact that it's actually happening. Being able to have, develop a relationship with children, where you're able to speak openly about these things as a parent. It's very difficult as a parent, I think, as well. Especially again, especially in our climate. I know that my mother definitely did not talk to me about anything like this when I was growing up, because they just didn't in those days. But I think we have a responsibility to have those clearer conversations now with our children. At the age that you feel appropriate for them, I'm not saying talk to them when they're 9 or anything, but at an appropriate age to them understand. I mean, for instance, we're giving young girls now an HPV vaccine against cervical cancer when they're 12 and 13. So, you have to have a conversation with them about why they need that. They're not having sex yet, but they need to understand why it's important to protect themselves, from the potential of catching this cervical cancer causing, virus. So, I think the onus is really on us, just to be a bit more, just to sort of understand the long-term goal. We're trying to protect the girl child, the boy child, from all these ramifications of poor sexual practices. So we just have to just man up a little bit and just have these conversations.
Can lack of sexual attraction affect partners, especially erection in men and libido in women?
I think if a couple have been together for a while, I would hope there's some attraction. And that attraction could come in, not necessarily in the physical attraction, it comes in mental, spiritual, and there are various formats where one can be attracted to another individual. The whole sexual attraction is slightly more complex. With time, the body changes. With time, the feelings change. I'm not a psychosexual counselor, so it's difficult for us to comment on this sort of topics. However, that is a problem. It is a problem if one doesn't find their partner in any way stimulating.
Yeah, and I was just going to say, I think from the female point of view, if she has a lack of libido, it's probably worth her having some hormonal checks done to see whether she's actually approaching the menopause. We know that even though the average age of the menopause is in your 50s, and we know that for a few years prior to that, you have a period called the climacteric, where your hormone levels are beginning to decrease, and you're beginning to get some sort of signs and symptoms of menopause. So if she's of that age, late 40s or something like that, and going through reduced libido, I would definitely advise, having some hormonal simple blood tests done, because they will be able to really give an indication whether she's approaching the menopause or actually already in the menopause. And that would then help in terms of maybe that's the medical reason why she's got reduced libido.
Sadly, it can. The nerves that supply a man's erection runs very juxtaposed to the base of the prostate. So if a man has prostate cancer and ends up having a radical prostatectomy, i.e. the entire prostate removed, often the nerves are often sacrificed during this operation. They are removed at the same time. Obviously, technology has improved. In the UK, most radical prostatectomy is done with the aid of a robot called the Da Vinci robot, and that allows better visualization of the male anatomical pelvis so you can dissect the nerves away from the prostate. But yes, it is very common for there to be an element of erectile dysfunction after radical robotic prostatectomy.
Another question, must a man wake up with erections in the morning?
I wouldn't say it's a must. It's physiological, believe it or not. It is normal for a man to get erections a number of times during the night. There's been studies looking at this, whereby there's thing called a rigid scan, whereby it's like a blood pressure cuff, where the patient having a 24-hour blood pressure monitoring. That's often put around the male penis throughout the night. And it's not uncommon when they go through REM sleep, rapid eye movement sleep, what's called REM sleep. So when they go through REM sleep, it's not uncommon for men to get an erection, but they're fast asleep. They often notice it because they happen to wake up to go to the toilet to urinate, and then they realize they've got an erection at the time. So it is very common. If a man is not getting early morning erection, there's often an organic problem such as diabetes, or they've had radical surgery or cancer treatment.
Are we saying then that the erections men tend to get in the morning are not really attraction erections, they're more just physiological erections, and therefore
it's purely a physiological thing. There's absolutely no excitement at all. Some of maybe our female audience might be a bit disappointed to find out that it is not personal. It is not personal. It's just a human physiological response. I think some men remain very sexually active throughout their life, and they don't lose it. Whereas if some men, if you go through a period where you don't have intercourse, it's not uncommon to suddenly lose it and find it doesn't return to the same figure.
People come in and say, I have weak sperm.
Yes.
Have you heard about this? And well, what is it? And is it real, or is it a fiction, a figment of their imagination?
I think it's an expression that we get, weak sperm. Patients come and say, my sperm is weak. And there's key parameters that we look at when we look at a man's quality of their sperm. We look at the volume of the ejaculate. We look at the concentration of the ejaculate. We look at the morphology, how good looking the sperm is. Believe it or not, 96% of sperm is abnormal. They have 2 tails, they're on crutches, they have 5 heads, they're really abnormal. So 96% of the male morphology, looking at WHO criteria, is abnormal. And also, we look at how well they swim. Okay, their forward progression. So whether it's front quarter, backstroke, or whatever. So there are 4 things we look at, essential things we look at. Now, believe it or not, the sperm outside the male organ is very unstable, and it dies and destroys very, very quickly. Okay, and believe it or not, the female vagina is incredibly hostile to the male sperm. So only the best survive. Only the best reaches the goal, has the right to actually allow conception. This is natural history. This is natural selection. So when a man says he has a weak sperm, it's often based on laboratory findings that the quality of their sperm is a bit suboptimal.
How can women who lack sexual desire be helped?
Well, I think, again, it's important to maybe get to the root cause of what could be causing that. I think for women, I think we know that for women, emotional connection is critical in sexual arousal and sexual function. Whereas for men, it's all physical. So a man will see a naked woman, he's good to go. A woman might see a naked man, she's not going anywhere. So, we need a bit more help. We need our husbands to do the washing up in the morning, to take the kids to school in the morning. So for us, that is foreplay for women. So already, by the time we get home in the evening, he just arrives in the evening and says, "Hello, here I am. Nothing is happening."
Yes.
So it's counseling, communication, exploring. But like I always say, rule out the medical things like maybe menopause or anything like that, or even sort of physical aspects where maybe you've got some vaginal tightening or things like that, or dryness. Rule these things out to try and treat them. But then I think a big part for women is usually emotional, and that just needs counselling and talking through.
Is that kind of counselling available at the Bridge Clinic?
So we have counsellors at the Bridge Clinic, which is all part of our fertility program, and our counsellors are trained in all aspects of counselling, and definitely psychosexual counselling is also part of what they do, because we do see, couples who have these kind of problems, libido problems. We see men who come and actually have erectile dysfunction problems as well. We see women who just have, these sort of what's called vaginismus, like the spasms in the muscle of the vagina, which makes sex very painful. Some women have something called dyspareunia, which is painful sex as well. They might need dilators. So our counsellors are there as the first line to help try and talk through the emotional, psychosocial side of things as well.
And Dr. Leye, just the last question for you. As a urologist, you're a male doctor.
Yes.
And so therefore, all these male issues are within your purview?
Correct. So in the UK, it's even a subspecialty. Most of it is done by urology, but we have a subspecialty called andrology, which deals with a lot of the male factor, erectile dysfunction, and sexual health issues.
Do you have any last words for our listeners?
As far as our male patients are concerned, I've mentioned to you the issue of Adam and metabolic syndrome. So by educating our male patients, and it's important, one thing I didn't talk about really was the fact that erectile dysfunction predates cardiac problems. There's been studies looking at men that have erectile dysfunction. 5 years on, some of them go on to have a heart attack or start developing angina. So to our male patients out there who suffer from erectile dysfunction, please seek medical help. It could be that one just needs their testosterone. It could be that, by seeking medical advice, you actually prevent yourself having a heart attack years down the line. So education, general well-being, regular exercising, good diet, all the things that I'm sure everyone's aware of what to do, is just finding the time to do them to make sure they have good sexual health.
I think for me, it's really just being aware, that your sexual health is really important for your reproductive health as a woman, and therefore just having those safe sexual practices when you're much younger is critical for you to have an uncomplicated reproductive life, when you actually want to start a family. And if you do find that you do, come down with or catch anything that as an STI, for instance, then just seek help early, and get treated early, and don't be ashamed of it. It's better to seek help and be treated than to try and bury your head in the sand and then come back at the age of 35 with your tubes damaged and you can't get pregnant.
Thank you very much.